From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to our listeners around the world. You're listening to the JAMA Clinical Reviews podcast. Thanks for joining us. I'm your host, Dr. Karen Lasser, Professor of Medicine at Boston University and Senior Editor at JAMA. Today, I am joined by Dr. Rita Kalyani, who is a Professor of Medicine at Johns Hopkins University School of Medicine, and will be speaking about type 2 diabetes. Welcome, Dr. Kalyani, to this JAMA podcast.
Thanks so much, Dr. Lasser. I am thrilled to be here.
And we're thrilled to have you. So to begin with, in your review, you state that type 2 diabetes affects approximately 1 in 6 adults in the U.S. and 828 million people worldwide. So who should be screened for type 2 diabetes?
Diabetes is growing around the world. And as you mentioned, estimates range anywhere between 589 million to 828 million. And so this increase in numbers really prompts us to think carefully about how we can prevent new cases from developing in the future. There are many guidelines for who should be screened for diabetes. The most common are from the American Diabetes Association and the United States Preventive Service Task Force. The USPSTF recommends screening for type 2 diabetes in adults aged 35 to 70 years who have overweight or obesity. That's a body mass index or a BMI greater than 25. And that screening should occur every 3 years for those with normal glucose levels. The American Diabetes Association, or the ADA, recommends that all adults aged 35 years and older should be screened for type 2 diabetes at a minimum every 3 years. Those of any age who have a history of gestational diabetes, who have overweight or obesity, that's the BMI of greater than 25, in most individuals or greater than 23 in individuals of Asian ancestry, along with other risk factors such as family history in a first-degree relative, such as a parent or sibling, are recommended to be screened every 1 to 3 years as well, depending on their risk status. So there's a wide net of people that could potentially be screened and benefit from early identification of diabetes.
That's super helpful. And how is type 2 diabetes diagnosed?
All types of diabetes, with the exception of gestational diabetes, use the same criteria for diagnosis. These rely on 3 types of tests that can be done on lab testing for diagnosis. The first is the hemoglobin A1C test, which represents a time-weighted average of blood glucose over the span of the red blood cell, about 2 to 3 months. An A1C level of 6.5% or greater is considered diagnostic for diabetes. The second criteria is fasting plasma glucose, and this is a glucose level that is drawn after 8 hours of no caloric intake. A fasting plasma glucose level of 126 or greater is also considered diagnostic for diabetes. The last laboratory-based test that can be used is the 2-hour plasma glucose test, and this is drawn after an individual ingest 75 grams of an oral glucose test or a 75 gram carbohydrate load. And a glucose level at 2 hours of 200 or greater is considered diagnostic for type 2 diabetes. Any of these 3 criteria can be used to diagnose diabetes. You only need one, but it does have to be confirmed either with a separate test, one of those second tests, or on a different day.
Yes. And one thing I find tricky in primary care is distinguishing type 2 diabetes from adult onset type 1 diabetes. So what kind of guidance can you provide about that?
That's a great question. And it's one that we're encountering more and more as we have come to understand over the past few decades that type 1 diabetes, which used to be called juvenile onset diabetes, can actually occur at any age. In fact, it can be seen in adults in any decade of life. And so it is important to keep it in mind when we see someone who's newly diagnosed with diabetes. Some of the Signs that can alert us that we should be considering type 1 diabetes in an adult who's newly diagnosed includes relatively younger age of onset, less than 35 years, a strong or personal or family history of autoimmunity, which tends to go along with autoimmune type 1 diabetes, or what we call a lean body phenotype, a body mass index less than 25, which can be seen with type 2 diabetes, but is not as common. In these individuals, we might consider testing further for type 1 diabetes with islet autoantibodies. Most commonly, we start off with the glutamic acid decarboxylase, the GAD antibody, and then if negative, can proceed to testing with other antibodies such as the IA2, the zinc transporter 8, or insulin autoantibodies as well to help differentiate whether it's type 1 versus type 2 diabetes.
And I didn't catch that. You mentioned an autoantibody IA2. What does that stand for?
IA2 is another type of antibody. It's known as islet tyrosine phosphatase 2 antibody.
Great. So let's switch gears and talk about treatment a little bit. So what is the role of diet and physical activity in treating type 2 diabetes?
Lifestyle modifications, which include diet and physical activity, are the cornerstone of diabetes management. In fact, any clinical guideline that you look at around the world has lifestyle management as one of the first line therapies that we offer, not only a diagnosis for type 2 diabetes, but throughout a lifetime of living with type 2 diabetes. And the reason for this is that we know that weight management in particular can be important not only to help with lowering of blood glucose, other metabolic benefits such as on blood pressure and cholesterol. So we consider lifestyle modification a cornerstone in the treatment of people with type 2 diabetes. And this includes medical nutrition therapy, which is individualized, in-depth nutrition therapy delivered by a registered dietitian. And then physical activity, which includes moderate to vigorous aerobic activity and also resistance activity as well. Our current guidelines recommend 150 minutes per week of aerobic activity, usually 30 minutes a day of 5 sessions throughout the week. And then resistance activity as well. Those are muscle strengthening exercises of about 2 to 3 sessions per week as well. And we know that physical activity not only can lead to benefits in lowering blood glucose, but it can also lead to favorable body composition changes that not only improve insulin sensitivity, but can help with glucose uptake as well.
Now, moving on to medications, what are considered first-line medications for type 2 diabetes?
That's an interesting question because this has been the focus of much of what has changed over the past 5 to 10 years. Historically, metformin has been considered the first-line medication for people with type 2 diabetes. Metformin belongs to a class of medications known as biguanides. It's the only one in the class currently available. It is primarily what we call a hepatic insulin sensitizer. It makes the liver more sensitive to insulin and reduces the production of glucose. So it reduces hepatic glucose production, which particularly reduces fasting glucose levels overnight. Metformin is relatively inexpensive, well tolerated, has high A1C lowering efficacy, up to 1.5% to 2%, and has been around the longest of any of the oral medications that we have currently. And so metformin has been one of the first medications that was considered first line for years in our clinical practice guidelines, particularly through the American Diabetes Association and also other guidelines around the world. Over the past 5 to 10 years, we have had several new trials, what are called cardiovascular outcome trials, that were mandated by the U.S. Food and Drug Administration to demonstrate cardiovascular safety. These began in 2008, and every new glucose-lowering medication approved for type 2 diabetes has to have what's called a post-marketing cardiovascular outcome trial. What these trials have demonstrated, by and large, is not only cardiovascular safety, but several new agents in the GLP-1 receptor agonist classes and the SGLT2 inhibitor classes have been found to further have cardiovascular benefit when compared to placebo. As a result, first-line medications for individuals who were included in these studies, which were by and large those with a history of cardiovascular disease, at risk for cardiovascular disease, high risk, or with a history of heart failure or kidney disease, now have preferential treatment recommended by our clinical guidelines with SGLT2 inhibitors or GLP-1 receptor agonists that have demonstrated benefits in these populations, either as first line, concurrently with metformin, or in some guidelines, even prior to metformin. This has revolutionized the way that we manage type 2 diabetes. In many cases, the guidelines recommend use of these agents with demonstrated cardiovascular kidney benefit in the SGLT2 inhibitor or GLP-1 receptor agonist classes, irrespective of the A1C levels. In other words, we might sometimes see patients in our clinic who are at their A1C targets. For most non-pregnant adults, that is often less than 7%, and yet still recommend use of these newer agents because of the benefits they have on cardiovascular and kidney reduction. It is important to note that in these trials that were done demonstrating cardiovascular benefit, more than 70% of individuals were on metformin. And so all the benefits that have been noted have usually been in the background of metformin treatment.
That's really helpful. Now, when should we still be considering prescription of insulin for patients with type 2 diabetes?
Insulin is the therapy that has been around the longest. It was first discovered more than 100 years ago, and we have seen tremendous evolution in the types of insulin therapies that are on the market. Insulin should be considered in those who have what we call catabolic symptoms, those who might have polyuria, frequent urination, polydipsia, frequent thirst, hyperphagia, feeling hungry a lot, blurry vision, all symptoms that go along with severe hyperglycemia, or unintentional weight loss, which can also occur in really high levels of blood glucose. This is often reflected with an A1C of 10% or greater. And in those people who have such high A1C levels or have hyperglycemic emergencies such as hyperglycemic hyperosmolar syndrome or diabetic ketoacidosis, it would be recommended on diagnosis that these individuals with type 2 diabetes be initiated on insulin treatment. In those who initially started on oral medications such as metformin, some of the newer medications I talked about, such as SGLT2 inhibitors or GLP-1 receptor agonists, or other medications that we currently have on the market, such as thiazolidine diones or sulfonylureas, sometimes with time, we need to escalate treatment due to the natural history of type 2 diabetes, which is that with time, we see progressive beta cell dysfunction where the body can no longer produce enough insulin to overcome the insulin resistance in the body. In up to 1/3 of people with type 2 diabetes over their lifetime, they will require insulin treatment. And so we really see two groups of people requiring insulin. Those on diagnosis because of really severe or high blood glucose levels, and then those who over time, due to escalation of treatment, require insulin.
Sure. And as a follow-up to that question, which patients benefit from continuous glucose monitoring?
We have known that glucose monitoring can have great benefits for people with diabetes. In those with type 2 diabetes, blood glucose monitoring, which historically is what we had available before CGMs became popular, was more recommended in those who were taking insulin treatment, such as those who were taking once daily basal insulin or those who were on multiple daily insulin injections up to 4 or 5 times per day. Blood glucose monitoring through a glucose meter involves a finger prick using a lancet where individuals drop their own blood and then put this on a test strip, and then the glucose meter will register the glucose reading for them. Continuous glucose monitors, on the other hand, have become more and more available over the past few decades. I'll be using the terms continuous glucose monitoring or CGMs interchangeably. And these are diabetes technological devices, often the size of a palm, that can read glucose readings in real time and don't necessarily, with newer models, require patients to prick their fingers anymore to check their blood glucose levels. There are continuous glucose monitors that can register glucose readings every 5 to 15 minutes, what we call real-time continuous glucose monitors, and also those that are called flash or intermittent CGMs, those that register glucose readings on demand when you wave a scanner over the sensor. In people with type 2 diabetes, CGMs are recommended by current evidence-based clinical guidelines in those who are on insulin treatment, and may be considered for those who are on non-insulin treatments as well to help guide therapy, such as around dose changes or lifestyle changes as well. CGMs often have the ability to have alerts for high blood glucose readings and low blood glucose readings. And in those who might be at risk for nocturnal hypoglycemia overnight, CGMs can also especially offer benefits for reducing time spent in low blood glucose reading range.
Excellent. I have one more question. Is there anything else that generalists should know about type 2 diabetes that we haven't talked about yet?
The first thing that I would say is that while we talked about the symptoms that can occur on diagnosis with type 2 diabetes, the polyuria, the polydipsia, the blurry vision, unintentional weight loss, the majority of people are asymptomatic on diagnosis. And so it's really important to be aware of the risk factors for type 2 diabetes and to screen people who might be at risk for prediabetes or type 2 diabetes so that they can get identified early, as we already talked about. I just wanted to highlight a few of the other risk factors that may be important to keep in mind when we think about screening. We talked about family history, which includes having a sibling or a parent who has type 2 diabetes. Women with gestational diabetes have up to 40 to 50% lifetime risk of developing type 2 diabetes and should be screened. Older age, as people get older, they're more likely to develop type 2 diabetes as well. Those who have other conditions such as high blood pressure, high cholesterol, and cardiovascular disease, this constellation of metabolic conditions also can put someone at higher risk. And then belonging to a high-risk race or ethnicity. This includes people who are from Alaskan, American, Native American, Asian, Black, or Hispanic ethnicity. Those individuals are also at higher risk. And so I want to emphasize the importance of screening because that's so important to reduce the number of cases of people with diabetes in the future. We touched briefly upon prediabetes, and perhaps I should mention that prediabetes is a state where individuals have glucose levels that are higher than normal, but not quite at the levels diagnostic of diabetes. Fasting plasma glucose between 100 to 125, a 2-hour glucose between 140 to 199, as recommended by the American Diabetes Association, and an A1C level of 5.7 to 6.4%. Individuals with prediabetes should especially be monitored carefully and yearly for the development of type 2 diabetes and offered lifestyle modification interventions to reduce the onset. The other point that I'd like to mention is that the vast majority of people with type 2 diabetes are treated in primary care. More than 80% of individuals with type 2 diabetes are treated in primary care. And so it's important to recognize that resources need to be available for use of these newer technologies that we mentioned, and being familiar with these newer medications that have cardiovascular and kidney protective benefits, and offering them to individuals who would be recommended by our evidence-based clinical guidelines to be on them. Referrals to endocrinologists can be considered in those who seek to have further guidance on initiating technology, in those who are on complex regimens such as multi-drug regimens, multiple daily injections, or high doses of insulin, 200 units or greater, and those who have lack of expected response to treatment, like we talked about, those for whom we might consider, could they really have type 1 diabetes or another type of diabetes? Those would also be individuals that could be considered to referral to endocrinology. So that would be just another point to emphasize that we really work together in partnership in primary care and specialty care for management of type 2 diabetes.
Well, this has been tremendously helpful. I'm Dr. Karen Lasser. I've been speaking today with Dr. Kalyani from Johns Hopkins University School of Medicine about type 2 diabetes. You can find a link to the article in this episode's description. This episode was produced by Shelley Stephens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts.
This content
Thanks
is
for
protected by
listening.
copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.